Good evening, everyone. Welcome to the Epilepsy Foundation of Connecticut, our winter webinar series. This is Monica Anzalone, and I'll be moderating the webinar for this evening. And for the purposes of sound quality, everyone has been put in listen-only mode, but we do welcome you to type any questions that you may have at the bottom of your screen. You'll see a little chat icon, and you can type your questions there, and they will be answered at the end of the presentation. Today, the webinar will be a discussion about the newly approved medication Epidiolex, which is a cannabidiol preparation, how we can prepare this medication to medical marijuana and other CBD preparations available, what is known about the science of this medication, side effects, and indications. Let's now introduce our presenter, Dr. Jennifer Madan-Cohen. She is a pediatric neurologist with a subspecialty training in EEG and epilepsy. She's the head of the Epilepsy Center at Connecticut Children's Medical Center, which provides comprehensive care to children with epilepsy. The center provides multidisciplinary care for children with epilepsy, including potentially curative epilepsy surgery. The ketogenic diet program is the largest and longest running in the state. Dr. Madan-Cohen is also the director of the Neurodiagnostic Center, which provides EEG, epilepsy monitoring unit stays, visual evoked potentials, and brainstem auditory evoked potentials. I would now like to hand this over to Dr. Madan-Cohen.
Hello, everyone. Thank you for joining us this evening. I am going to have some slides for us to look at, but I mostly am going to be talking. And we're going to go through some of the things Monica talked about. So to start out, I just want to thank the Epilepsy Foundation for doing this, because I know there's a lot of people who have questions out there. And I'm happy and proud to be part of the Epilepsy Foundation, and I'm on the professional advisory board. So I'm glad to be able to do this talk for you. There we go. So just to start out, I want to explain that I was a principal investigator for the Connecticut Children's site of 3 of the Greenwich Biosciences trials for Epidiolex. That's the brand name of cannabidiol. We had 10 patients in the trials. And because of that association, I was asked to be a paid speaker by Epidiolex to do trainings for other doctors and healthcare workers about the medication. They are not paying me to give this talk, however, and I'm free to say whatever I want. So I'll just tell you some brief things. I think a lot of us know about epilepsy, but I'm going to specifically talk about Lennox-Gastaut epilepsy and Dravet epilepsy, and you'll come to understand why I'm highlighting those two. I'm going to talk a little bit about basic science, a little bit about history, and what is available now. So as we know, epilepsy is not just one disorder, but many different disorders with the common symptom of seizures. And patients with 2 or more seizures in their lifetime or certain syndromes that predispose to recurrent seizures have epilepsy. And we know that I just sort of did some math in the lower half of the screen there to think specifically about us in Connecticut. If we think about kind of average numbers based on what we know about epilepsy in different portions of the population, about 10,000 people have intractable epilepsy in the state of Connecticut. That includes somewhere around 2,500 children. And if you look at specific syndromes, the Lennox-Gastaut syndrome and Dravet epilepsy, there's probably about 200 or so patients in Connecticut with these 2 diagnoses. That's just to give some perspective on what we're talking about. So Lennox-Gastaut epilepsy is a seizure disorder where you have usually more than 2 seizure types. Atonic seizures are head drops or falls. Tonic stiffening, atypical absence, which are staring spells with or without eye flutter, myoclonic seizures, which are quick arm jerks, full body convulsions, and partial seizures, or otherwise called focal seizures, which are seizures that can start in one part of the brain and spread. And the onset of these seizures are usually in early childhood, like 2 or 3 years old. There's a classic EEG associated with it called slow spike and wave. Etiology means what causes the epilepsy, and most people are with Lennox-Gastaut epilepsy have some neurologic problems before their seizures start, and that can be from a wide variety of brain problems. Some patients, it's the first thing that we see as a sign of a neurologic problem, but we know that patients with Lennox-Gastaut epilepsy often have brain malformations, strokes, genetic disorders, but some are idiopathic, which means we don't know why, but we assume that there's some other thing going on that we just don't have good testing for. The natural history of Lennox-Gastaut epilepsy is that there's a high rate of intellectual disability and a high rate of infantile spasms as a prior history. And then many patients become intractable, meaning not responding to medications, with frequent convulsions and drop seizures. Dorvet syndrome is a form of epilepsy, again, where you can have multiple seizure types. The most common are myoclonic seizures, those arm jerks, and then also convulsions. And fever and heat can provoke seizures in patients with Dorvet syndrome. Onset is typically in the first year of life, often with a prolonged febrile seizure, like a febrile status epilepticus, and myoclonic seizures. And the EEG is often showing generalized spike and wave, and often has background slowing. The natural history of Dorvet syndrome is that there are often, after the seizures start, a notable cognitive and other developmental impairments. And there's a higher than average rate of early mortality, meaning death, and a rate of sudden unexplained death in epilepsy up to 20% of patients with Dorvet syndrome. And again, epilepsy is intractable. Patients can have hundreds of seizures a day, convulsions several times a week. The etiology of Dorvet syndrome, meaning the cause, is mostly felt to be genetic. About 80% of patients are known to have an SCN1A gene mutation, which is a sodium channel. There are some other genes as well, which are listed there, that are known to cause Dorvet syndrome. And then there are some patients who look exactly like other patients with Dorvet syndrome, but who are not found to have any one of these particular genes. And it's probably that there are other genes that we just don't know about yet in medical science. So we'll come back to those syndromes, and I wanted to explain those sort of right off the bat. So let's talk about the hype. What is going on here? So the media and the internet portrays CBD and medical marijuana as safe, effective, and good for like practically everything. And you hear a lot of reports of things like it being a miracle that gave me my child back. And I know that a lot of families tell me they feel a lot of pressure and even a lot of guilt. Like if they're not giving their child medical marijuana, they're not doing everything that they can for their child. And I know that there are a lot of well-intentioned aunties and grandmas out there who are hearing what's out on the internet and getting in everybody's ears. And some of the hype started back in 2013 when CNN did this profile called Weed that showed this patient, Charlotte Fiji, who has Dorvet syndrome and who was in a similar way to many patients I see, where they've tried a lot of conventional medications and are still having lots of seizures, and her family was searching for something, and they ended up trying a strain of medical marijuana, which has since then been dubbed Charlotte's Web, which was a high CBD, low THC strain. So as we know, there's lots of hype. So if you go on the internet, you're going to see things like Does CBD do anything? Here, you can buy it free shipping for orders over $125. What's CBD oil? Should you use it? How much should you take? I mean, you're just inundated by this information. So let's just talk about what is really out there and what's not known. So here's some basic science. And if you look at cannabis, which is marijuana, the genus term for marijuana, cannabinoids are the chemicals within marijuana that we think have effect. So the top two that are looked at are known about are THC, which is that long-term tetrahydrocannabinol, and that's the component which is felt to be psychoactive, meaning it produces a high. And the other top one right now is called CBD, cannabidiol. And that's not known to be psychoactive. That does not produce a high. Within the body, we have something called an endocannabinoid system. And this is the part of our system that helps us. This is inherent in our bodies. Our bodies make certain chemicals that affect this system. And it helps us do things like relax, eat, rest, forget, and protect. So it modulates, it helps us with eating, anxiety, learning, memory, and growth and development. So what are these chemicals, this THC and CBD, what are they thought to do? So the THC is thought to activate the cannabinoid receptors and help sort of turnover. Those are fancy terms for synthetic, and they degrade the enzymes. They help sort of things turn over faster. So it stimulates the cannabinoid system, cannabinoid receptors. The CBD seems to modulate not the cannabinoid receptors, but other parts of the cannabinoid system. It's not really clear, though, exactly what the CBD does. And there are some studies showing anti-inflammatory and possibly neuroprotective effects. And there's some thought that CBD reduces the psychoactive nature of THC, sort of balancing it out. But they're thought to work differently. So if you look at street marijuana, meaning illegal marijuana that you can buy to smoke to get high, it's been bred to have very high levels of THC. And if you look at street marijuana of today, meaning 2018, versus the street marijuana you got in the 1970s, the THC levels have just gone up and up and up. And so street marijuana today is actually much more potent and much more addictive than it was even 10 or 15 years ago. And then you have other medical marijuana out there, strains of medical marijuana that are bred to have varying levels of THC, some low, like say Charlotte's Web, and others in the middle. And if you walked into most medical marijuana dispensaries around the country, you could get a variety of different components. And I'll talk about that a little more. So historically in neurology, there are some different times when epilepsy and other neurologic issues were cited to be where cannabis was cited as a treatment for them. So like in medieval times, there's writings about Islamic physicians using cannabis to treat epilepsy. In the 1800s, it was used as analgesic, meaning a pain medication. In the US dispensary of 1854, cannabis was suggested for neuralgia and depression and pain relief. And in 1960, there was an Ohio Medical Society that quoted the use of cannabis for infantile convulsions and epilepsy. So it's been around out there as a thought, could we use this for seizures? So before 2015, however, there were really only a few case reports, and I'm not going to go through all of these. This is just so that it gives you an idea. There was a handful of case reports showing cannabis actually using it for a medical indication. And these are reports of more of a medical report that we can cite and look to if we're going to look at what's the data. And so you can see there's not that many. There was this Cochrane review. That's a kind of review that we do of scientific literature where we pull together all of the studies on a particular topic. And before 2015, there were only 4 published trials, and they didn't find any effect. Although the studies, 2 showed improvement, but all of the studies were flawed in the way they were designed and very small numbers of patients. So people always say to me, why do you care so much about data? Because I believe in science. And I also see studies like this one and I get worried because people really want to believe that something works. And sometimes if we are hoping strongly enough, we can see things that aren't really there. So this study was out of Colorado where they looked at the charts of patients that they were treating, and they noted that about a third of the patients, I don't know if you can see my marker here, but about a third of the patients reported a 50% reduction in seizures. But they noticed that if the family had moved to Colorado for treatment, the responder rate was higher than if they were in Colorado. Now you can imagine ways that that might have been the case, but they felt that the 2 groups were really equal. So it's not to say that the patients didn't respond, it's just sometimes we hope for things so badly that we move to another state for it, and it makes us more willing to believe that it was helped. And I want the data. I don't want to just believe that something's effective. I want to know that it's effective with good data. So other than the trials of Epidiolex, we don't have a lot of good hard data on CBD and medical marijuana products. So Epidiolex is a purified CBD. It's made by a company called Greenwich Biosciences. And they sponsored and published the results of 3 trials. And as I told you, we had patients in actually 2 out of those 3 trials. 2 of the trials were very similar. They were there were 2 on Lennox-Gastaut epilepsy and 1 for Dravet epilepsy. And the patients who were in the trials had to have intractable epilepsy, meaning they had tried at least 2 medications and were still having seizures. And these were patients who had fairly severe seizure burdens. They had to have, for Dravet patients, they had to have 4 convulsions a month. And for Lennox-Gastaut patients, they had to have 2 drop attack seizures per week. The trials were done over 4 months period, and they were double-blinded and placebo-controlled. And that's a word that should ring for you because that's sort of the most rigorous type of scientific study. So that means that neither the patient nor the doctor knew if there was actually this cannabidiol in the bottle. And the reason that's important is because we don't want to just, we want to try and separate out how much is effect of the actual medicine and how much is that placebo effect, that effect of like, this must be working, so I'm going to get better. And, you know, the body's ability to heal itself is quite remarkable. The families actually really had to put a lot of work in for this trial. They had to call in every night to an automated system to report the number of seizures. That helps with what's called recall bias, meaning you think back over the past month and you don't quite remember things the way they are. So if you have to call in every night, we're trying to be as rigorous as we can. And the patients all had various different things measured, blood work, side effects. We had to do rating scales for development, for suicidality, for all kinds of different things. So what came out of the trials? So the study showed that about 40% of patients in the trials had a greater than 50% decrease in the convulsive or drop attack seizure numbers. And there were a few patients who were seizure-free. About 20% had more than 75% of their seizures go away. but the rest had 50% or more decrease in their seizures. So again, not seizure-free for the most of the patients who responded, but significant decrease in seizure numbers. So let me tell you about side effects. What we found is that about 1 in 10 people had some kind of side effect. Most of them were mild and didn't lead us to want to stop the medication or change the therapy at all. Agitation and other mood change were seen. Sleepiness, fatigue, and lethargy were seen, and that's bolded because that was one reason that a few patients did need to leave the trial. Diarrhea was seen in 1 out of 10 patients. A decreased appetite was seen in 1 out of 10. And then liver inflammation was seen in about 13% of patients. That's also bolded because there were some people who had to leave the trial due to liver inflammation. However, most patients had very mild liver inflammation that went back to normal when we checked it next without changes to the medications. Sometimes we had to decrease the dose of Epidiolex or a dose of another medicine they were on. And like I said, there rarely was the need to come off of the Epidiolex because of it. It did seem to be worse with a higher dose of Epidiolex, and there was also more liver inflammation if the patient was on a valproate, which is Depakote, and also to some degree if you were on clobazam, which is Onfi. And so what has been recommended by the FDA is that you have blood work before you start Epidiolex at 1 month, at 3 months, and 6 months of therapy. And what else is known about Epidiolex is that there are some drug-drug interactions. So we talked about Depakote already causing possibly more inflammation to occur, liver inflammation to occur. But we also have to worry a little bit about clobazam, which is Onfi, because Epidiolex can increase the blood level of clobazam, and clobazam can increase the blood level of cannabidiol. So sometimes we need to adjust the dose of it so that we don't have side effects of the clobazam, like the sedation. And so based on these studies, the FDA in October approved Epidiolex for the treatment of Dravet and Lennox-Gastaut epilepsy. So all CBD is not equal, right? So I said that Epidiolex is cannabidiol that is produced by a particular biopharma company. But you can get CBD in a lot of places, or at least I will say you can get things that claim to be CBD in a lot of places. So the FDA, this is just a screenshot of the FDA's website. They have put out warning letters and testing results for some cannabidiol products. And basically what they found is that a lot of the products that reported to have CBD did not actually contain the amount of CBD reported, or some didn't contain CBD at all. A little bit scary is that some of the products actually had contaminants in them, and certainly the FDA did not test every product out there. So it's hard to know what you're getting. It's hard to know what you're getting if something claims to be CBD. Okay, so what about hemp oil or hemp seed oil? So hemp oil is oil that's taken from the seed or the flower of the hemp plant. It does not naturally contain CBD in any kind of high levels. So most hemp oil is either low in CBD or was bred or genetically modified to contain higher levels of CBD. Hemp is also used to clear soil of toxins, meaning whatever's in the soil ends up in the hemp and in the hemp oil. So if the hemp is grown in a contaminated soil, your hemp oil product is going to be contaminated. So it's really important to know where your product is coming from. And unfortunately, it's really hard to know where your product is coming from because companies can buy hemp grown overseas and process it in the US and then sell it as a US product. So you don't actually know a lot of times where the hemp is coming from. And just sort of late breaking news is that the federal farm bill that was just passed within this week changed the classification of hemp and took away some restrictions to growing it. So it will now go to the states to be regulated, but hemp was previously not legal, and now the Farm Bill has sort of changed the restrictions on that. It did mandate that hemp contain less than 0.3% THC, but it's not really clear yet what's going to happen to hemp that has CBD in it. Is that going to be regulated differently or not? So here's the slide with all of the data supporting the use of THC and other cannabinoids in epilepsy. Okay, note that it's blank. No studies were done yet, and it's kind of hard to imagine the FDA allowing THC-based research in children because it's known to be a hallucinogenic. That doesn't mean it won't be done, and that doesn't mean there won't be data that will come out about THC. I personally have looked at some of the charts of my patients who've gotten medical marijuana preparations in the state, but the numbers are so small it's hard to draw conclusions. And so I'm sure that somebody out there is going to publish some observational data, meaning what they saw in patients, but it's hard to think that there's going to be something like a randomized placebo-controlled trial. Other cannabinoids are being looked at, like CBDV and various other components, but there is no data out yet. So what is the difference between what I've been talking about and medical marijuana? So in Connecticut, we have a pretty, what I would consider reliable medical marijuana program, meaning the products that you would get in a medical marijuana dispensary are tested and labeled as to the content, and particularly if you're getting oil-based products or sometimes tablets, the batches are tested so you know how much THC, how much CBD, how much of the components are in them. And at least you know that the growers and the dispensaries are regulated, meaning like they're not growing the marijuana or hemp or whatever in contaminated soil, and that the labs are clean and there's not like rat infestations or something, I don't know. So at least you have that level of safety. You don't know, again, we don't have data on the actual medications in them, but at least you know that safety. Intractable epilepsy is an indication in Connecticut for medical marijuana. Under 18 years of age, you need 2 physicians to certify that you have intractable epilepsy. Products are available in Connecticut that are all CBD. But there are also many products that contain other cannabinoids and THC. It's generally fairly expensive. Like most of my patients who've gotten products before Epidiolex was available had pay about $200 to $400 per month, and it's not paid for by insurance. And despite what the dispensaries say, there really isn't data about effectiveness, even though I've had patients tell me that the dispensary pharmacist told them this, that, or the other, that if there's some THC, you don't need as much CBD, etc. So just in conclusion, Epidiolex is available as an FDA-approved medication. There's science and data to support that. There's history to support it. And there really is no clinical trials on really anything else, so I can't tell you a lot of data about other things. And my sort of editorial is that you have to be careful not to let public opinion and desperation lead to premature treatment decisions. So everything should be a dialogue, a discussion with your physician who knows you or your child, and knows what kind of seizures they have, knows what kind of reactions they've had to medications. And, you know, as physicians, we always try to first do no harm. So we want to make sure that the treatments that we're giving are not going to cause additional harm. And so I think with that, I will take, I'll look at the question. Hopefully some people wrote some chat questions in. I don't know if I can see that. Monica, are you there? Can I?
Yes. So just as a reminder to those that may have come on late, if you do have questions for Dr. Madan-Cohen, go ahead and type those on the bottom of the screen. You'll see a little chat icon at the bottom, and it will appear, it will flash like an orange color when somebody does have a question. So we'll take a few minutes and give you some time to type. I know this is, you know, an exciting topic for people just to kind of learn more about, and so we'll just take a few minutes there. Oh, did you see that? Do you see that one, Doctor? Okay.
Yep. So great. So the question is, Epidiolex safer than traditional medications, or are side effects comparable to traditional medications? So it's a great question. It's a little bit hard, of course, to compare two medications, and traditional medications encompass a wide variety of things. So for any one patient, there may be some issues that you need to discuss with your doctor about using any particular medication. But I would say, you know, if I look at things like, I think the levels of mood and sleepiness are pretty comparable to what we see in other medications. So, you know, for example, Onfi or Depakote, those medications have a rate of sleepiness and mood change. And I don't think that we'll find that Epidiolex is any different from those in terms of that medication, in terms of those medications. If you look at the liver inflammation, the reported rates of liver inflammation for valproic acid is about 1 in 20,000. And as I said, the Epidiolex is 1 in 10. So it's a little bit hard to compare apples to apples because we don't have the same kind of studies on the Epidiolex, on the older traditional medications, than we do on the CBD or the Epidiolex. But the liver inflammation is the one thing that is certainly known to be higher than in the other medications. And it's something that we would be screening all patients for. And like I said, most of the patients who had liver inflammation, it resolved on their own, or we were able to get it to resolve by changing either their dose or their other medicines. So I hope that answers the question. I'll just say that I'll just add one other part of that I get asked a lot. And the thing that a lot of people say to me, well, it must be natural, so it must be safer because it's coming from a plant. Mm. And I would just have to say that I would love it if that were true, but the truth is that it's cannabidiol is just a medicine that happens to grow in a plant. And just because it's from a plant doesn't mean that it's more natural, and it doesn't mean that it doesn't have side effects or harmful effects. And the thing I will cite most about that is poison ivy. So, you know, poison ivy is a plant, but it's certainly not something that you want to use to treat yourself with. So it can be harmful. So we have to be careful about what we're taking and putting into our bodies, of course. Any other questions out there that people want to ask? Okay, so what is so there's two questions here. One is, how many medications would you think a child should fail before trying Epidiolex? I think that most patients with Lennox-Gastaut or Dravet epilepsy have tried multiple medications. There isn't a number that is required to fail before being able to be prescribed Epidiolex for those two diagnoses. There wasn't a requirement of like you have to have failed 2 or 3 medications. I think that it's not going to be my practice to use Epidiolex as a first-line medication if I'm diagnosing someone with either of those 2 forms of epilepsy. But it's certainly not gonna, it's certainly something that I will be prescribing for my patients and have prescribed. Another question here is, can you get a prescription without a Lennox-Gastaut or Dravet diagnosis? People online say you can. So that's a really good question. It kind of remains to be seen what's going to happen. And the reason I say that is because as physicians, we can prescribe a medication. That doesn't mean that the insurance company will pay for the medication. So, and will approve it, allow it to be dispensed. So I say that not because I want to put the burden onto the insurance companies, but right now the FDA indications are Lennox-Gastaut and Dravet. I think that there are likely arguments to be made, and I will, admit that I will make them if I feel the situation is the case, that I think a patient without one of those 2 formal diagnoses might benefit from it. But it's not clear yet how far they're going, the insurance companies are going to go to make us sort of prove what kind of epilepsy someone has. So I hope that kind of answers the question. It's not a clear answer because it's not clear to me yet where the line is going to be. If the insurance companies want to be sticklers, they could say, no, you haven't provided documentation of these 2 diagnoses, and therefore you can't get the medication. And that's happened to me in some cases for some other medications that I've tried to prescribe. That's called prescribing off-label, quote unquote off-label, OFF label, meaning the FDA has labeled the medication as something and you're trying to prescribe for outside of it. Now, in pediatrics, we regularly prescribe things off-label because there aren't a ton of studies done in children. So it's not unheard of for things to be prescribed and dispensed off-label. It just kind of remains to be seen. And I think certainly if people have tried and failed several medications, it's not unreasonable to think that you could go through an appeal process to see if you can get Epidiolex approved. It certainly helps if you have features that are similar to Lennox-Gastaut and Dravet epilepsy. Any other questions out there?
I know that most of the people on here are parents of children with epilepsy, but this is something that is prescribed as well for adults. Is that correct?
Oh, yes. So the clinical trials were actually done on patients from age 2 to 55. And so it is indicated for children and adults with Lennox-Gastaut and Dorvet syndrome. The Dorvet studies actually were for patients age 2 to 18. I think that's more just a factor that there aren't a lot of adults with the Dravet diagnosis since it's a newer described epilepsy syndrome. but the Lennox-Gastaut group, and including the patients that I saw, included adults. So yes, it is indicated for adults as well. And I will just add that there aren't a lot of there weren't a lot of cognitive kind of side effects noted to the medication. There was some agitation, some sleepiness, but there wasn't side effects noted of like cognitive slowing or difficulties with speech, anything like that. And there certainly was some data to say that quality of life was improved with Epidiolex, and that's sort of a broad measure of how well do you think the patient is, or the family member is doing on the Epidiolex. We certainly have seen some patients who seem to have done better cognitively, meaning their seizures are decreased and they seem to be speaking better or interacting better or able to do more. That is not something that was seen in all patients for sure. Many patients didn't have a change in their cognition. And it's not something that the FDA would say is a benefit of the medication, where that's not something that was proven to be a benefit. But some patients we did see improvements in.
And what would be your advice for any of these parents listening now or who will listen to this recording that might be interested in investigating more? As far as where they're getting their information from, what would be your suggestions to these families to get the information that they are looking for to kind of...
Yeah, I mean, I think that you really have to have a discussion with your doctor about whether or not it's a medicine that your particular loved one you should be looking at for them. Because like I said, there are side effects and there are positives and negatives, and there aren't a lot of things known. So I've been asked about Epidiolex for all different seizure types, but if you noticed when I was talking, I really was talking about the science or the data that's known for convulsions and drop seizures. We don't really have a lot of data that shows that it works for absence seizures, for example, or for the myoclonic seizures that patients have, or for focal onset seizures. So, hopefully over the next year or 2 years, we might see some other studies about other seizure types. But right now, I can say that, we don't have a response rate in those kind of seizures. And in some ways, I wonder if we don't have the data because we can't see an effect, right? So certainly the patients in those groups that I talked about had a lot of those seizure types, but while we saw an overall response rate, I can't give you a number on how many of them had a decrease in their absence seizures as well. We don't have data on that. I don't get a particularly good feeling about it. I mean, I had some patients in the clinical trial, and I didn't see a big difference in some of their other seizure types. But again, that's not science. That's like my feeling. So I don't want people to make decisions based on that. And overall, Epidiolex is fairly well tolerated with the, what I described. So, the discussion has to be between you and your doctor about a risk-benefit ratio, and it's not going. The approval of Epidiolex is not going to change the treatment of the vast majority of my patients. If somebody came to me with a classic childhood absence epilepsy, they are still going to get the classic treatment for childhood absence epilepsy: ethosuximide, valproic acid, lamotrigine. You have to be someone who's very rare and outside of what I would consider typical for me to be considering Epidiolex in outside of Lennox-Gastaut and Dravet patients.
Thank you.
You're welcome.
Well, if anyone does not have any further questions, we'll go ahead and close tonight's session. I thank everyone who participated for taking the time to listen in, and a reminder that this has been recorded and will be available on our website at epilepsyct.com. And I would like to thank especially Dr. Jennifer Madan-Cohen for her expertise in this area and just for taking the time this evening for talking with us about this very interesting and important topic. Thank you.
You're welcome.
Good night, everyone.
Good night.